Good morning, everyone, and welcome to another episode of our CME. Remember, our dates are fixed. It's the second Wednesday and the last Friday of every month. And you may have seen the notice before we started. There will not be a CME on Friday, the 28th of May, in honor of our Medical Association of the Bahamas Conference. So please join us for our Medical Association Conference on the last Friday of this month. Also, please remember to submit your poster abstracts for the competition. I will place my email in the chat so that you can email me your abstract to participate in this year's competition. Remember to fill out your CME claim form, and we will also place the link in the chat so that you can claim your CME. Good morning, welcome, and a very special thank you to Dr. Halliday for the lovely pre-music and pre-CME pictures. And congratulations to our colleagues in Freeport on your new emergency room. So this morning we have a very special guest presenting to us, but to introduce this morning's guest, we are going to ask our consultant and general pediatric surgeon, Dr. Shani Knowles, to introduce her. Thank you, Dr. Knowles.
Thank you. Good morning, all. So today I have the privilege of introducing one of my consultants when I was a resident in training. Professor Elmi Muller. She's a transplant surgeon and has worked in the field since 2005. She's a graduate of the University of Pretoria, where she did an MB CHB. She attained a fellowship at the College of Surgeons of South Africa in 2004. And subsequent to that, she received the MEd in 2007 and a PhD in 2018 at the University of Cape Town. She has an active interest in promoting organ donation and transplantation, especially in lower and middle income countries, hence the topic this morning. She is the president-elect of the Transplantation Society. Elmi really became quite, I would say, famous because she pioneered the first HIV positive to positive organ transplantation at the University of Cape Town. And it was the first in the world. And the outcomes of these transplants have been published in the New England Journal of Medicine with 3 to 5 year follow-ups. So today's topic is setting up a transplant unit in a resource-limited environment. This topic is quite timely because we have 2 recent fellowship-trained nephrologists, Dr. Ria Carroll, and a transplant surgeon, one of my colleagues, Dr. Vanterio Taylor. So it's really good timing for this talk, and I hope that we get good feedback and have a good discussion. So you can go ahead, Prof. Elmi.
Thank you so much. It's a wonderful honor to be with you today, and I really appreciate the introduction from a very dear colleague who we've spent lots of times together, and I'm sad I'm not with you in person, but at least we're able to share some knowledge and to start possibly a working collaboration on something that's very dear to my heart. I'm going to share with you today some of the things that I think are important when we have to discuss setting up a transplant program, especially in a resource-limited country. And my experience has been mostly to address the main obstacles to increase organ transplantation in Africa, but it is also relevant to any developing country, and I think, in your setting that would be especially important too. So the thing that we need to consider when we think about setting up a transplantation program is to look at what approaches we can use when we have to start planning our resources and planning our discussions in our different healthcare systems. And basically, some healthcare systems are really ready to justify a very distinct offering. So something that's very tailor-made to their system. and we can reach them quite easily. And I think the Bahamas system, as I've read it, is really one of those type of places where you are ready to expand on your clinical service. You are ready to start thinking about doing things that you haven't done before. And transplantation obviously lifts the level of everybody. So it doesn't only have an impact on surgeons, but it also has an impact on physicians. It has an impact on laboratory personnel, on technical expertise. And basically, transplantation is a wonderful opportunity to lift the level of knowledge and resources in your hospital. But when we start talking about setting up a transplant program, we also have to think a little bit wider. Do we only talk to doctors? Do we talk to hospital groups? So in some countries where there's private and public partnerships, that's important. Or do we think about the broader context of the Department of Health, for instance? And I think it's important that we consider all our sort of said customers for maximum gain. So if we start this process to think about all the stakeholders, and obviously in each country it's going to be different. So we need to think about where it is that you are, and that is probably something we can do in the discussion. But basically, you want to try and get a description of where your clinical service is at the moment, and that includes both surgical, medical, laboratory, and then look at what would be your needs at the moment if you would start a transplant program, and then what would be your future needs. So for instance, many countries start off with a small living donor kidney program. Then I want to move to a deceased donor kidney program, and then I want to move to a deceased donor liver program, and then I want to move to a deceased donor heart program. But it might also be, because you have an opportunity to set something up right from scratch, that you don't have to follow these steps, that you just simply leapfrog into something that addresses all your needs. And then important also to think about your future needs. So for instance, in our kidney program in Cape Town, we started off with doing normal relevant, well-matched kidney transplants. And for a long time, that's the only thing we've done. But now we've started to do ABO incompatible transplants. We started to do transplants for very sensitized patients. So it's important to plan for these future things that you might want to do, and then to look at the gaps of what needs to be addressed if you want to do that. So I think starting off, you would make your stakeholders aware. We've spoke about it in the previous slide, but that includes a wide range of people: hospital managers, Department of Health, the medical practitioners that's going to be involved. And we mustn't forget about the patients. They are important in our discussions and help us to drive some of these potential opportunities, because they are the ones who are in need. Then to evaluate where you are now, what have you got in place in your system, and what new offerings do we have to do? So what are the things we need to solve? What are the gaps? Then plan the delivery of the service. I think important to create a timeline, and then to continue the use of the service. So to contextualize it for your patients, make it user-friendly for your staff, make sure you don't lose important role players in this system, and then of course long-term maintenance and support to your system. Now this is quite a busy slide, but I thought it's just important if you think about it from a business perspective, because many times when we set up things, we think about it from a clinical perspective, and we simply concentrate on what it is that we need to do. Oh yes, we need to do radiology, we need to do pathology, but we have to sort of think when we start the transplant program about it in a very broad context. So I'm going to share these slides with your group, and I'm happy if anybody who wants the slides can have them. But these are the sort of just thinking for me, what are the important relationships and partnerships that you need to think about? And I'm not going to discuss everything, but what I want to say from this slide is that there are key partnerships internationally which can help you. TTS, WHO, the Declaration of Istanbul Group, then your own Department of Health and their experience. So it's important from the beginning, bring them into this. Then there are key customer relationships. And that is probably something like your community, personal things between doctors and patients, but also thinking about opportunities. How will patients get referred? Will they be able to self-refer? Is there an option where they can use some sort of automated service to get into your transplant program? And how will you share this information? Then in the second to bottom key, I don't know if you can see my cursor, but I think it's important that we concentrate on some of these things. We need to think about cost, and everything we do in medicine has to have value. So we have to bring to the patient something that is cost effective and gives them great value. And I wrote here economies of scale considerations, because of course, the more you start doing, the more value you bring, and the easier and the more cost effective it is. Why do I say that? If you employ a transplant surgeon who does 5 transplants a year, that person is quite expensive in terms of what it offers to patients and to the hospital system. But if you employ a transplant surgeon who does 50 transplants a year, it becomes much more cost effective. So that person is still working for the same salary, but be able to do a lot more. So when you plan your cost structure, I think it's very important that you try and think big, because I think many times when we start planning, we think, oh, let's just start small. But I think it's nice to think big. Then the other thing to think about is things like data collection and sharing of outcomes. It's a very big problem in the developing countries, and it's a huge opportunity. So if you would set this up right from the start and make sure you collect all the key metrics, you're also setting up wonderful research projects. You're thinking about potential to expand your service internationally, have more cooperation, include other revenue streams. So for instance, include research revenue streams, include affiliations, include cooperations with other societies or with the private sector. And then I think the very important thing at the bottom is to make sure there's a good interaction between the dialysis program and the transplant program with kidney transplantation, and to make sure that there's excellent trust and protection with some outcome guarantee to your patients. We can't, as surgeons, ever say to patients things will just be always perfect, but we can make sure that they know that all the safety measures are in place and that they will feel confident and protected in this program. Now, I'm going to discuss what I feel are the 6 main groups of barriers to increase transplantation in low and middle income countries. And I haven't been in your country, so I don't really know if all of this is relevant to you, but I think it does give you a little bit of a perspective of those things that are important when we set these things up. Now, deceased donation always comes up because obviously if you want to do liver and heart transplants, you have to have some form of deceased donation. And that's why I said right from the start, I would, if I'm you, think big. So think about starting something that includes deceased donation right from the start. What do we need if we want to do that? We need some form of legislation on brain death. So your country has to acknowledge that as a form of death, and there has to be a legal pathway in which you can certify a patient as brain dead. Then you have to have infrastructure, personnel, and a capacity for coordination between these things to support deceased donation. So in Cape Town and in South Africa, we use transplant coordinators. It's a little bit different from the US system where that infrastructure is outsourced. And I know that there's a large amount of coordinators in the USA who work through external agencies, but in our context, we employ our coordinators as part of our hospital staff, and each hospital has got transplant coordinators. Then a very big barrier can be tissue typing and cross-matching facilities. If you want to have a deceased donation program, you have to be able to get a donor and within 24 hours have some form of tissue typing or cross-matching done to see if it's a good match to your recipient. And that can sometimes be a barrier, and is something we must, in the discussion, talk about if this is a barrier for you as well. Of course, with the deceased donation, you need an on-call surgical team. And with that, I think, one of the things that you need is a team that might not be completely dedicated only to transplantation, but who is prioritizing transplantation. Because what happens is you get a donor on Sunday night, you realize Monday is going to be transplant day, and you have to change what you've planned. So whether that is an elective slate, or whether that is a clinic, or whether that is administration, you have to change your Monday. And my experience with surgeons who do many different things is that they struggle then to, for instance, put off an elective list. It's possible, but it needs some form of commitment, and that is very important. Of course, for deceased donation, we need buy-in from the public because they need to give us consent. And that can be quite a task to make your public aware of deceased donation, to make them understand, to make them sign up, to put those processes in place. And, something we can also talk about in the discussion. Therefore, in advocating for deceased donor transplantation, the requirements in terms of resources, infrastructure, a track record, and capacity for coordination needs to be realistically acknowledged. And it's important that we realize it's not only about a surgeon who's unable to put a kidney in, there is a bigger picture here and needs to be considered. I think the second big consideration for us in developing countries is cost. But even in high-income countries, that's a big consideration because you don't want to do something that's so costly that it breaks your healthcare system. Now, we haven't done enough research to look at the cost of transplantation and follow-up care and maintenance immunosuppression in the developing world or in the low and middle income countries. I think there's a lot of work that needs to be done there. And many times when we talk about cost, we quote data that comes from Europe and the USA. And then usually we say transplantation is cheaper than dialysis because in the first year you just pay for the surgery. In the follow-up you pay for the immune suppression, which is cheaper than dialysis. And I hope this is true in our setting as well, but it needs to be investigated because maintenance immune suppression in countries who doesn't get bulk import, who doesn't have, as I mentioned before, the economies of scale, that can be quite a different scenario. Now, you get places, and I've just put here Cameroon, where, for instance, the government will pay for a patient to travel abroad to receive a transplant, but when the patient returns, they must pay for the immune suppression out of pocket. And that, of course, creates new problems because when people don't have money, they don't come, and they lose their grafts, as it affects long-term outcomes. So I think it's a very important consideration when we talk about the cost of immune suppression, that we also are realistic about our patients traveling abroad and what happens from that. Then I've spoken about the cost of maintaining a functioning graft versus maintaining somebody on dialysis. And I think this is something that would be an interesting study in your geographic area to look at whether that is cost effective. And as I said, I hope it is, but I think it's important to prove that also when you start discussions with things like the Department of Health. Now, any successful transplant program can't happen as an island. It happens in an ecosystem. And to happen in an ecosystem, I think we have to realize that we need some form of positive government involvement. We've struggled with that in South Africa, I'll be completely honest. I think in many ways, our government is not that interested in transplantation and haven't supported it that much. But we were lucky that there was a sort of reasonable infrastructure over the last few years put into place, and we're able to continue to work within this infrastructure. However, the fact that the government isn't really prioritizing transplantation means that we as transplant groups are struggling to grow our transplant programs. Further, I think it's important to involve your Ministry of Health when you start working or looking at the legislative framework. And in my experience, it's very difficult for us as professionals to drive transplantation as an individual or an individual institution. So it's nice if you can have a wider buy-in it's important that it happens at one place, but it needs to be supported from a large group of stakeholders. And in my experience, that is a very important part to consider. Now, of course, we can't have transplantation if we don't have the professionals who will drive it, who will support it, who will do the transplants, and those are important concerns. So I think in terms of training and expertise, you have got people who've finished fellowships, and you're very privileged in that way. In many countries, we don't have that. But I think now it's important when you start planning that you make sure you keep your expertise, I want to say, together in one center or in one place. So plan, choose, and negotiate right from the start. Don't have a scattered program where one patient is done in this hospital, another one in this hospital, surgeons are not working together. Their best chance of succeeding, and also for the surgeons who have to do these transplants, is if they do all of them in one center and they support each other and you build up the expertise in this one center. That doesn't mean other centers and other places can't refer patients, can't follow up patients, can't collaborate in this program. So have a very open collaboration, but try and bring your expertise, especially your surgical expertise, to one point. Something to think about is how you address the brain drain of professionals. So in my experience, many physicians and scientists leave their home country, they go and do some training, and then they don't come back. That might not be a big problem for you. It's a very big problem in Africa. So what I want to say with this point is that we have to look after the people who have these skills and who are driving it for us. And we have to try and create a working environment that is going to be attractive to them and keep them in your unit. With living donor operations, I think physician expertise, nephrologists, immune suppression, people who do lab work, those are really important in general in transplantation. And it's important to have people who understand these issues and who are trained. But when we talk about living donations and living donor operations, we have to have the surgical expertise. There is nothing as difficult as a living donor operation that doesn't go well, or a living donor transplant where the organ, for instance, doesn't work or gives problems. So you have to make sure the surgical expertise is there. And all I can say is we learn lifelong. I still feel I learn every time I do operation. You're never perfect, but you have to be able to be safe, and you have to be able to be confident in the operation that you offer, especially to a living donor. Then this is a very big problem, and I don't know if that's such a problem for you, but transplant and travel sort of is two things that happen a lot, and it happens because of two reasons. Either there isn't a good enough program in the country where the patient is coming from, or there's an issue around donor exploitation or organ trafficking. And of course, traveling for a transplant, if there's not a good program, is absolutely fine. But traveling for a transplant where you're going to pay a donor or have an organ trafficking is a very big problem. Now, really, I don't know if patients currently are traveling out of your country to undergo a transplant out of the country. But when you start a new program, I find that this is a big barrier, because in many of the African countries, this is happening. They're sending patients abroad to Tunisia, Pakistan, India, and then the local program doesn't want to grow because these practices continue. And there's a lack of confidence in the local physicians and the local surgical team, and the patients remain going abroad, or referrals happen to those places. And there's even sometimes financial incentives. I know some of the Indian hospital groups give a financial incentive to a nephrologist if they send a patient to their hospital. So I think those are things I can just say from experience that can make it very difficult when you start a transplant program, and perhaps something to be very open and frank about and to discuss right from the start. Now, I've mentioned this before, and I want to sort of come back to this. you've got a wonderful opportunity to do research, to publish what you're doing right from the start, to set up a registry for your renal replacement therapy, both documenting dialysis and transplantation, to report your outcomes, to plan your treatment in a way when you start a new program, you can do it right from the start. And that is what I think is the wonderful thing about having no program and starting from scratch, because you can really make it, tailor make it exactly like you want to do it. Costing in your country needs to be examined. You need to look at what is the cost of the immune suppression, what is the true cost of the transplant, and compare it to dialysis, and then try and look at cost saving measures, potentially bringing down cost by, for instance, doing more or importing more immune suppression, something like that. We always emphasize prevention and screening programs. It's a very basic need of a good healthcare system. And if you are proceeding with a transplant program, please do it in line with a very good prevention and screening program. For instance, diabetes, hypertension, HIV, those things need to be sort of hand in hand with your planning for end-stage renal disease. I think there's wonderful opportunities for you for research, for funding, for private-public partnerships. And, you know, I'm sort of excited that you're going to go into this thing and have this opportunity to tailor make your program. So I thought that this would just be a nice summary of things that you need. And as I say, I'm not going to go through every slide in detail, but I can share my slides. So just to emphasize, you've got surgical expertise, ICU, critical care, laboratory, you've got nursing support, surgeons, physicians, anesthetists, radiology. All those things are things you have to think about when you set it up. You have to think about the actual basic needs in terms of these 4 categories. So laboratory is very important, and that involves not only tissue typing, but also things like pharmacological levels, UNE, full blood count, infectious disease screening. Your medical services, obviously you have that already in place, but you have to think about your physicians, let them understand the transplant drugs and the transplant immunology. Your surgical services, remember what I've said about centralizing your surgeons, training, teaching, bringing in new people. And then other essential services, infectious disease is important. We in Cape Town don't have dedicated infectious disease people with our transplant program. We have got access to infectious disease expertise, but in many other countries there are dedicated transplant infectious disease physicians. And then radiology and pathology are important, but there are also opportunities. We are looking at, for instance, opportunities to share pathology amongst a large group of people, so that you don't have to have transplant pathologists across the world, but that you have one digital sharing of information with many different pathology reports possible on that sort of set of slides. So those are all ways of trying to make things a little bit easier. Governmental overview, it can be very complex, but it's important that you have to think about your governmental overview, specifically your legislative framework, your agreements with patients to travel abroad. Those are all things that can be discussed at a higher level. There are important things I want to emphasize, for instance, confidentiality, import and export of organs, which I don't think will be that important for you, but I don't know if you're thinking of sharing across borders, and then to have something in prohibiting organ trafficking in place right from the start. So that is my slides, and I thought we can now move perhaps into a discussion or questions, and just talk about some of the things I've seen in African countries or other places where we started transplant programs, or any questions you want to ask me. Thank you so much.
Thank you very much, Dr. Muller, for that very revealing and explanatory presentation. as we are all aware of the need and the benefits of transplantation in our country. So Dr. Shani Knowles is still with us, and he is going to lead the discussion. Dr. Knowles?
Okay, thank you, Elmi. That was an excellent presentation, and it really highlighted with us, about to start up and get a program off the ground, some of the things that are important. One question I had, as far as legislation and living related, how does that work? As opposed to the brain death.
Right. So we are currently looking at many African countries' legislative frameworks, and we're finding that there are lots of gaps in the legislation. It needs, strictly for a transplant program to function properly, you need some form of legislation around the living donor, just basically to prevent exploitation of a living donor. In an ideal world, you would want a legislative framework that address the issue of organ trafficking and address the issue of trafficking of humans, of removing organs, and address the issues like reimbursement of expenses versus financial gain. So generally, we don't want people to get financial gain out of donating an organ, but we are very comfortable to have them in a financially neutral position. For instance, if I have to pay petrol to come to the Transplant Institute and I'm going to donate an organ, it's okay for me to get the petrol reimbursed, but it's not okay for me to receive $200 just because I attended. So those are the type of things that could be in a living donor, either in a legislative framework or in a guideline document, which is centrally sort of okayed by the government. For deceased donation, as I said, it is about brain death legislation and accepting neurological death.
Okay, thanks, Elmi. I think Dr. Vontario Taylor, he's on the Zoom, and just want him to chime in on if he had any questions or to add to the discussion.
Good morning. My question would be, how do you walk the fine line of discouraging the commerce aspect of it, or having people profit from it, and making sure that you can reimburse your potential donors for any expenses? Do you put a cap on the amount of money that you can give them over the time that they donate? Or is it some other method, do you think?
So we in South Africa are not able to reimburse expenses. The reason is that the amount of money we have available for transplantation is very limited. And in my government hospital, I don't have the opportunity to tell people, bring me your expense documents and I will reimburse you. In the private sector in South Africa, it's also not really happening. We don't have a fund in which we can do that, although in the private sector, sometimes we can claim stuff from the medical recipients' medical insurance. But if you look at a place like Canada, for instance, who have taken financial neutrality quite far, they are working on a case-by-case situation where there's a central fund that's run by the government, and they will reimburse you literally for a slip you bring in. So you will say, I had to overnight in this hotel, I had to eat this lunch, I had to spend this money on travel. But it's not a reimbursement at the moment for instance, time off work, I think it's simply covering the expenses, that money you have available, what you can do. And in my opinion, that will have to be tailor-made to whatever your situation is. But I would recommend that it's a central fund that has got specific rules, and that it's not like a round amount that everybody gets, that it's not something like everybody gets $2,000, but that it's specifically related to, to the true expenses.
Thank you for that advice, and thank you for a lovely presentation.
Shani, I have a question for Prof.
Okay, go ahead, Dr. Magnus.
This Professor Ekididi, Professor Muller, I spoke to you before. How are you doing?
I'm good, thank you.
That's a wonderful presentation. I think there is probably I want to find out what you think about brain dead patients whose organs are very good to be used, especially in our community, because it's not a program that has been established. People find it difficult to harvest the organs unless they see that the heart has stopped. And we have lost so much important organs here that could be used. I remember in 1997, that was a big deal because a family member of a patient that died in a motor vehicle accident would not allow his 22-year-old son's organ to be harvested. Anyway, that was a little bit uproar. Having said that, what advice do you have in this situation? Do you suggest forming a committee or something to look at every patient that is potential donor, that is potentially brain dead, in terms of relating the story to the family so that they can be receptive about having these organs? What do you think? Thank you very much.
So I think, in my setting, we also have issues with consent with family, and they will sometimes refuse to donate. And it might be that the organs are excellent, but the family refuses. We see that as well in South Africa. It is a very important thing to have the trust of your community. And whatever you do, you can't lose the trust of your community. So if you want to get those organs, which is refused by a family or that is not consented for, the key to getting those organs is to do better public education programs, or to have a better process for informing the family and trying to get your consent rates higher. It is, I think, if I understood you correctly, you were also asking me about marginal organs. So sometimes you get consent for an organ and the organ isn't that great. So I think it's about prioritizing, almost like a step-by-step approach. If you have a brain dead patient, you ask the family. If the family says yes, then you look at the organs. And you look at the quality of the organs and whether they will benefit your recipient. And that can be, for instance, I can have a sort of slightly poorer quality kidney, but I can give that kidney to somebody in his 60s, and that person will have still 10 years with that kidney, but I probably won't give that kidney to an 18-year-old. So sometimes it's about also matching the quality of your organ with your potential recipient. If you don't get consent and you find that that's a major stumbling block, there are lots of training programs for coordinators. There are lots of models in the world. I know the Spanish have done a lot of work on this. Croatia has got a lot of experience, and we can talk about that. It is also for us a very difficult stumbling block.
Okay, Dr.
Thank you very much. That was an excellent response. Thank you.
Okay, go ahead, Dr. Morgan.
Good morning. Good morning, Prof. Muller. Beautiful presentation. Well, I guess my question is concerning a transplant immunology type question in terms of the laboratory arm of a transplant service. I know you guys use the laboratory for tissue immunology at the NHLS, right? In terms of HLA typing, I know your lab is accredited by the European Federation of Immunogenetics and Histocompatibility. What is the, if we were to form our transplant service, would we have to be accredited, or are we able to, once you have the laboratory expertise, could you use any laboratory, or would your laboratory have to be accredited?
You know, it is quite a technical question, and we can take it further after this presentation, and I can put you in contact with people who are really experts with this. But in my view, you would start by simply getting your laboratory able to process the most basic things. So they must be able to do a basic cross-match, yes. And then they must be able to do some of your donor-specific antibodies, which is going to influence how you're going to immune suppress. And HLA tissue typing does come in there, because if you have a full HLA picture, then you can work out which is going to be your higher and your lower risk patients. So I think, in my view, I would start by simply getting those processes in place. Then it depends on your local rules and regulations, but I don't think anybody can dictate that you have to get your lab accredited. You can do what you want to do. I mean, I can't tell you you have to get your lab accredited through a European rule or an American rule. But what you want is you want to be confident as a transplant group that the results is going to be right and correct, and that the kidneys are going to be put into the recipient, and it's going to be safe. And the reason why people get accreditation is because they want to have that sort of safety standard, and I think that is what the reasons. But getting that accreditation brings a new set of problems. So I'll just talk about it very quickly. But in Cape Town now, my lab is accredited. And to keep their accreditation, they need to do tissue typing bloods every 3 months. And tissue typing bloods is very costly.
Yes.
And we as physicians know that our patients' tissue typing doesn't necessarily change unless we give them blood or there's some other immunizing procedure. So now I'm forced to send my tissue typing bloods every 3 months to the lab because they want to keep their accreditation. My patients have to pay for this, but actually in practice, it's not really making any impact. So, you know, I would suggest that one goes, looks at what the lab requirements are, make sure your processes are safe, that people are well trained, that those things are in place, but that you then go and look at, you know, what is the best thing for your local system? Is it simply to have a yearly visit from somebody who comes from an accredited lab and just give you some advice? Or is it to go the formal accreditation route? And I think it also has something to do with your patient population, your risk for medico-legal issues, how much it will be accepted locally if you don't work with an accredited lab, you know. But I'm very happy to put you in contact with my lab and also with experts on this issue. I know some experts who work on this issue and who can help you more.
Thank you.
Okay. Prof. Muller, we have a question from the chat. It's just asked, Dr. McPhee asks, can you explain the challenges of ABO and compatible transplants that you mentioned earlier?
So we've just only started this about 2-3 years ago. And we started it because we found that our living donor pairs often needed it. We initially wanted to have a paired kidney exchange program, but it also wasn't always working. And therefore, you know, we thought, okay, let us also look at an ABO incompatible transplant. My experience with it is actually very positive. We've had very good outcomes, and in many ways, I think it was easier for us than to do the highly sensitized patients. So what you will need, our blood bank does that, or the hematology lab. can work out for a patient their anti-titer. So if you're a O positive patient, you can get an anti-A or an anti-B titer from the lab, and you can then get a sense of how much this patient will react if I would give that person an A or a B kidney. So let's say, for instance, I am an O positive patient. I have a B positive donor. We want to give the B positive donor to me. Then I will have to work out what is the titer in my blood against that B blood group. And that will vary. So some people will have extremely high titers, and we would say, no, this is not going to work. It's just going to be too complex to bring it down. And other patients, the titers are not that high, and we feel we can bring it down. And then we usually use rituximab as a sort of starting dose, and then we do plasmapheresis 3 or 4 sessions before the transplant. We keep on monitoring the titer, make sure it comes right down. And when it's right down, like a 1 in 2 or 1 in 4, even a bit more, 1 in 8, we can accept, then we will do the transplant. And the interesting thing about it is, if you get the patient through the first 2 weeks after transplant, and you make sure they don't reject their kidney in that first time, after that, it's not a problem. Once again, I'm a surgeon, so I'm very happy to put people in contact with physicians and immunologists to work with these things. But it's been, for us at Cape Town, we've had very good outcomes with our ABO incompatible transplants, and it was not as stressful as you think. I see there's another question. Where are we with transplants in the Bahamas? And I think that is something that I can't answer, but perhaps Dr. Knowles will answer.
Yeah, I think Ontario can probably comment on that. And if there's Dr. Smith, Dr. Smith, he's also a transplant nephrologist, and Dr. Rio Carroll, they can comment on that. But I'll let Ontario start.
Good morning, everyone, again. We were basically in the infancy stages, laying the groundwork. I'll let Dr. Smith and Dr. Thurston comment a bit more, but we're basically laying the groundwork right now.
Hello?
Yes, we can hear you.
Yeah. Oh, good morning. Thank you, Dr. Muller, for your presentation. So like Dr. Taylor mentioned, we are definitely in the infancy stages. I think for us right now, we're trying to sort out the basics, like firstly, government support to try and get a transplant program off the ground. We're trying to organize laboratory testing, a transplant team, a facility where this stuff can take place. So there are a lot of things that we're trying to, and even legislation, like trying to work on to try and get the program up and running. So one of the questions I actually had for you, I know you mentioned like government support would be important. So let's just say if we had put pen to paper and we could come up with a dollar amount for how much a transplant would cost. And then you have patients who have insurances that would say, okay, I'm going to pay for this. But the government is saying that we are still going to pay for dialysis, but we won't pay for transplant. How do you make transplant available for those patients who can afford to pay, but that the government at this moment in time is not willing to support the services?
It's a very important question. And the issue here is also that dialysis is driven by a large industry. So we've got Fresenius, we've got Adcock Ingram, we've got loads of companies who's driving dialysis and who are stakeholders in the dialysis machine. And for that reason, dialysis, two things happen. We do more and more and more dialysis. So economies of scale applies and it becomes cheaper and cheaper and cheaper. But it will never be that cheap because we have to always have nursing staff. We always have to have infrastructure with machines. There's always a human component to dialysis, which is not cheap. But I think consumables, etc., is becoming much cheaper. For transplantation, we don't have this. We have to try and make people aware of transplantation options without having that massive force behind us. And for that, I think there are two things we must emphasize. We must emphasize to the patient that issue of bang for your buck. What is going to give you the best bang for your buck? If you're going to pay $100, do you want to pay it for dialysis, or do you want to pay it for your transplant immunosuppression? But because we don't always have this information available, we can't always make this case. So I think it's important that we look at that in a very detailed way, and we show people how much money they will save. The second thing is quality of life. So quality of life on a transplant is much better than quality of life in a dialysis setting. Now, you asked me, how do you get to patients who are on dialysis and make transplant available if they can, for instance, pay? I think it is dangerous to embark on a program that's sort of a here and there thing for patients who pay cash. I think it's better to decide now on a timeline, and we put a working group together, and I'm happy to help with that. And we say, okay, this is the timeline. Then we want a transplant setting that's going to be able to transplant everybody, and people then who want to pay cash for it and want to get themselves helped earlier or whatever, that's okay. But I would be careful to not set up something now quickly just because somebody's got the money, because I think then you can easily run into trouble.
All right. Okay.
But having said that, sometimes you just need a jump start. So perhaps if you have a group of people who all want to pay for their transplant, I don't know, then perhaps one put together them all and you say, this is going to be the start of our program. We can get them all, they're going to pay cash, and then we're going to show their good outcomes, and we're going to show the hospital administrators and Department of Health how good they did. That's another way, I guess, of doing it. And the truth is there isn't the right answer. But whatever you do, I would just say, try and get the team together right from the start, try and get the data collection done right from the start, and then take it from there.
Okay, thank you.
Can I make a comment, please? Can I make a comment, please?
Go ahead,
Yes.
Dr. Roberts.
Yes. Thank you. Very interesting talk. I just want to say that we are not in the infantile process of transplantation in the Bahamas. We are actually in the early beginnings of transplantation, getting the infrastructure in place. We performed the first transplant in Nassau, the first kidney transplant, as early as 1996. And then about 3 months later, we actually did 2 transplants within our public institution, with both patients and their donors returning home within 5 days with normal kidney function. So it's not that it's not possible for us to have a transplant service available. We actually had a very well organized transplant service with a transplant coordinator and teams. One of the joys is to have a first-class institution next door in the Bahamas. We're right next door to Miami. And so they were support services. We were able to get tissue typing done within less than 24 hours. We were able to get our drug levels done, and so to monitor them appropriately within 24 hours. So it's possible to be kind of isolated on the island, but have a support service whereby you can perform transplants. Our problem really had to do with cost, in that the government supplies or provides some 70% of the cost of care in the country. And as a result of that, you would expect then that dialysis is predominantly provided by the government services. And so we couldn't get the government commitment to have the extra funding for what you would need in order to expand a dialysis transplant service as well. And then you have the issue whereby you have to be very honest in starting a transplant service, that it's difficult for the nephrologist to move from becoming more dialysis-centered to one that is transplant-centered. So you need a nephrologist who has that commitment to do that. And so we actually had a great team put together. Unfortunately, it was in the private institution. And when we tried to accommodate those individuals who were in the public institution, they did not have the funding. And so that is the first thing. The second thing we had, unfortunately, being close to the United States, and the point that you made earlier, in that the private insurance companies, where those individuals who could afford a transplant wanted to have the transplant done in a center of excellence. And so I want to support the point you made earlier, where how do you develop your center of excellence if you're not allowed to do your transplantation at home? So we had the direct competition of a place outside. And certainly to make sure, we said that the best way to start would be to start with live donor transplants. And that's how we started. And you wanted to make sure that that your transplant went very well, because the greatest disaster is when something happens in a live donor transplant. So in each of our transplants, we wanted to make sure we had the support and the backup of the transplant surgeons that were doing one every day. And so we always had, I was fortunate to have the support of my colleagues from Canada who would come down whenever we did the transplant. And so the prime issue we have to deal with here is one of organization, but more importantly, has to do with funding. And so I just want to say that in developing countries, we will always have the obstacle of funding. And if you look at the development of any transplant program anywhere, it never took off until you had the support of the government with regards to providing the funding for it. And so we're looking forward. I think we have a great group of young doctors who've come back, both on the nephrology side and on the transplant side. And if we are able to get for them the funding from the government, I think we'll have a great transplant program. I just want to add, in terms of legislation, you can't wait for legislation, because legislation takes time. And what we were able to do actually was to define the protocols and have them accepted by the coroners as to what we would define as brain dead. And that made it very easy. And again, we had the support of the University of Miami, who, whenever we had a brain dead declared, that we were able to have their team come in and harvest organs. And we'd have organs available for home for use. So I think we have all the pillars available. It's a matter of trying to have the umbrella organization to put them together. And if that is supported by the government funding, I think that we can have a great transplant program. I look forward to seeing that happen. But that's where we are with transplantation in the Bahamas. Thank you.
May I ask you something? Isn't there an opportunity, if you build your program up and you look at all these issues around cost in a very sort of with new eyes, and possibly come up with transplantation that's a bit more cost effective and better organized? Will you not be able to perhaps draw some patients from the USA to the Bahamas for a transplant?
Well, it's interesting you said that. We tried to do a coordination with a group from the United States. We were going to have an altruistic donor program, and we had set that up to do that with the infrastructure and have international surgeons as well. Unfortunately, it never got off the ground. It didn't get off the ground because the prime drivers from the United States that were involved in this program, unfortunately, one of them, the key person, was a transplant recipient, and in the middle of the process lost their transplant. And so I think that was a damper. But what you're saying is that we had looked at that having a formal altruistic donor program, having your transplants done in the Bahamas. So we were well on our way to do that, and we had a formal proposal for that.
Right, thanks.
Yeah, but I just want to say we should have published it, but we went through a period where we had the full support of the nephrologist, And we went through a period for 2 to 3 years where we had some 40 donors aligned with recipients. And we evaluated them, and we were able to show exactly where were the challenges. And the challenges, first and foremost, was that of funding, because we couldn't get, for those who had, who were insured privately, and they could find donors, then we couldn't get the funds to evaluate the donors. That became a problem. And then it took time. Evaluating donors is not easy. So on average, we took some 6 months to 1 year in order just to have the donors fully evaluated. And then when we did eventually evaluate, we were able, from 40, we actually came down with 6 pairs that we could use. And then when we came down to the 6 pairs, we actually ended up where the private insurance companies refused to pay except for 1. And so we ended up moving from 40 potential or hopeful donors. We actually ended up with doing 1 transplant over a 3 to 6 year period. So I think that put a damper on our movement for transplants in the private sector. And I think where we stand now is that we really need to have the government to look at having some national health insurance system where transplantation is a principal service or principal benefit that will be in that package.
Thank you. Those are excellent points, I think.
Thanks, Dr. Roberts, for your contribution. Prof. Muller, Dr. Roberts he's a urologist, and he's actually the dean of the medical school there.
Wonderful. Thank you for your comments. I thought they were very, very good.
I just wanted to say I did a transplant fellowship in Canada in 1986, where at that time we were the single biggest transplant center in Canada. We were doing some 100 plus transplants per year. And so I came home very eager to start a transplant program, but unfortunately, we did not have the infrastructure at all in order to really start. So it took quite some time some 10 years before we were able to do the first transplant. But that's how it is in low resource countries.
Yeah, exactly.
Okay, thanks again, Dr. Roberts, for your contribution. So it's 9 o'clock. Thanks, Prof. It's good seeing you after 10 years for your talk. It was very exciting talk, and it blew a lot of discussion. And as Dr. Roberts did say, it's not the beginning, but we're just, trying to get it up again. But the challenges with cost is a big challenge on the government. But we want to thank you for the presentation, and we really appreciate it.
Thank you so much. I put my email address in the chat box. If anybody wants to chat to me further, or if you want the presentation, and I'll also put my cell phone number for WhatsApp if anybody wants me to do anything with them. I'm also happy to refer you on to colleagues in both the lab and in the medical side, and can give you contacts from that side. Thank you so much for the opportunity.
Okay, thank you. I don't know if Dr.
Yes, I'm still here, Dr. Knowles. Okay. Thank you very, very much, Dr. Muller, for that presentation. And thank you very much for joining us from South Africa. I know it's afternoon for you, so you're getting towards the end of your day. So thank you very much for taking time out to share with us and show us, what you're doing over there and what we can do over here to expand our program and get it off the ground. So thank you very much. And thank you to you, our audience, for joining in. We will make sure that you have Dr. Muller's contacts should you want to get in touch with her. Please fill out the CME link. The feedback link is in the chat, and the code is, it is optimistic. The enrollment key is optimistic so that you can claim your CME. There will not be a CME at the last Friday of this month. we encourage you to join the Medical Association Conference. And please remember to send in your abstracts for your poster presentations if you would like to participate in the competition. So everyone have a good day. We will see you next time. The next CME will be on Wednesday, June the 9th. And thank you very much to Dr. Halliday for all his technical support. Have a good day, everyone.